Secondly, there is some rationale for doing this type of lesion using ESD. So I've just put up a bigger 1P lesion, which clearly in these figures you're going to use a snare to do that. For the bigger lesions, which you've often got a broad stalk at the bottom, the length of this can be variable, but there's a broad stalk here, and there are two issues with this. The first issue is they've usually got a really chunky vessel going through the center of it, and there's a high risk of bleeding. And secondly, in relation to the diathermy, what happens is you're cutting through this and it's very thick tissue. And what happens is that as the tissue heats up, it passes through these stages. And if it heats up beyond 100 degrees and closer to 200 degrees, because you're using a snare, instead of cutting through or dissecting the tissue, you're going to get carbonization of the tissue. And what usually happens is you start off all right, close the snare, then it stalls. And it stalls because the snare is now coated with carbon. And the very thing you want to cut through slowly, which is the vessel in the center, is compromised because the snare effectively is not working very well. And often you find it very difficult to engage the snare. The other thing is because it's so big, often you can't understand whether you've got a nice horizontal plane across the stalk or you're cutting it tangentially and you're leaving part of the polyp behind. So for that reason, there are some difficulties. The other thing is there's cancer in the center. It's not always that obvious. And the bigger the lesion, the bigger this risk is. And if there's cancer in the center, you start to get something called muscle entrapment, which I'm going to come to in a moment. So to control the bleeding, to make sure there's no muscle entrapment, and to ensure you get a complete resection, probably we're going to move away from doing snare resections and clipping if necessary to ESD. And I have to say this has been a shift in my practice, and for the larger 1SP lesions, we do ESD. I don't use these devices at the bottom, but for the starter guys, these are quite good. These are like using a pair of scissors as against using a knife, and you probably transition from one to the other. For the very big lesions, it probably takes a little bit too long to use this type of device. So I think the benefits of ESD are controlled and a safe resection. If there's occult malignancy, it has an optimal approach. The vasculature, as you've just seen, is better defined and can be controlled. And if there's muscle retraction demonstrated, you can release the muscle, or it can inform where you're going next with the resection if you feel this is related to malignancy. Traction is really useful for access and it gives you stability, but it does obviously mean the procedure is longer. If there is intraprocedural bleeding, this can be really significant and can be a big issue. So controlling the bleeding before it happens is very important. And then I think what we saw in the first case, there was the mobility of the polyp head can lead to torsion and rotation during the resection. And this can be very, very disorientated to the operator. And what I really, and we haven't got to the feedback, what I really like in the last case is certainly towards the end when we're getting down onto the pedicle and freeing it from the muscle wall is the way we brought the scope, or you brought the scope back and used the cap to get an overview, then go close, get an overview, then go close. So you're constantly checking your position. You're constantly checking how the topography of the bowel and the various layers are mapping out. So you can then be very precise about where you put your knife, and you do that by the visualization, the distance away from the pathology because of the cap, and the angle your knife is going to come out in relation to the snare accessory that you've got down. So this is the very first case Peter Jan did. He marked the stalk here at the bottom. We have a muscle there. We want to use a bit of traction. What I was trying to say is, firstly, your traction has to be in the right place. So if you're going to cut along this line, your traction has to be away from where you're going to cut, but on the side of the lesion. So if the lesion is upside down as it was, you want it at the bottom. If it's a normal configuration, you want it at the top above where you're cutting. So the point is your traction has to go in this configuration above your cutting line, in this configuration below your cutting line. It seems very straightforward, but you just need to think it through properly. And the dots definitely help with your orientation. I talked about muscle retraction sign, and what is this? Well, normally the muscle sits underneath The polyp grows, develops a vascular supply, and you can cut through here and you miss the muscle. In truth, what's actually happening is that this polyp started flat and it elongates, and as it elongates, it drags the muscle with it. That's how you form a stalk, and it drags a vascular supply with it, and obviously also draws the muscle with it. Now, there's a point of tethering here. Now, if it is a benign process, what happens is as you release the submucosal tissue and you free the vessels, the muscle layer drops out. If the muscle layer doesn't drop out, you've either got a highly fibrotic process or there is invasion. And by that, I mean there is malignant change here and it's invaded into the muscle and it has brought the muscle with it as it has grown. So if you have muscle retraction sign, you need to try and decide which of these phenomena you've got. And as I said earlier in the discussion, as you cut away the submucosa, the muscle layer tends to drop out if that is a significant issue. I'm just going to, are you guys ready for feedback? Or do you want me to do a little bit on traction? Or does anyone want to ask a question about that?
Then we do
first questions about
first questions, then feedback, then the next bit on traction later, maybe Jonathan, sorry. So, any questions on that? On what you just heard from John there?
Okay. So you've not really spoken about repositioning the patient here, but I guess that's just because sometimes your drawing is excellent as usual, but sometimes it's very hard to see where the base of the stalk starts and ends, and then to put your traction across to the opposite wall, it's sometimes it's much easier in the drawing than it's in real life sometimes. Any tricks on that?
So in fairness, I thought they both did a reasonable assessment. So you determined the head of the polyp, the length of the stalk, the orientation. I think there was a discussion in both cases about gravity and the effect it would have on the head of the polyp. I mean, if you're using a simple snare resection, ideally you want the head of the polyp going towards the oral side and having the stalk in front of the scope. That's probably the optimal position for a simple snare resection. For an ESD, probably it's less important because you can orientate your snare, but ideally what you want to do is you want to stretch the stalk such that it is freestanding in space, because your knife's going to cut through all the mucosa. So you want to tether it so that the stalk is suspended. And it was very interesting listening to the discussion David had in the second case where he said this was going to be the difficult bit. And I don't know whether you guys picked up on this, but I can't remember the word he used, but essentially the area he was cutting was not under tension. And what I mean by that is that if you're going to use an ESD knife, the mucosal surface that you're cutting or the tissue that you're cutting needs to be under tension. If it's not under tension, when you apply the diathermy, it doesn't separate. It just doesn't move. And the effectiveness and the efficiency of the knife to cut through that, it makes it very hard work. So an example for you guys on the learning curve is if you don't sufficiently inject your initial injection when you're doing your submucosal injection for your first incision, and the mucosa is intense, the knife cuts very less effectively and it is potentially more dangerous than if you have a nice lift and you have a nice dome and a really nice cushion, and the knife will cut through it very, very easily. That's because the surface mucosa is under tension. Similarly, in a pedunculated lesion, what you want to do is you want your traction to exert a force which pulls the stalk down to exert the traction to allow your knife to cut. The flip side, and the important thing to think about, is that as you're doing that, if there's muscle, it will pull the muscle down. Okay? So NASA, we had an exchange online. And when we're doing this type of lesion, let me just show you one last thing before you get to the feedback. I'll just show you exactly what I mean here. If I can share this. Can you share my iPad, David, if it's possible?
Could be possible now.
So let me just show you this drawing, and then we'll feedback. So if you guys can see that, what you have here is I've drawn the polyp dangling down and pointer here. So we have a patch traction here, and this stretches this, makes it easier to cut. The problem is, because it's heavy, it can rotate, and I think that's what happened in the first place. You get slightly disorientated. As you pull down, you can also pull the muscle into the stalk, and that's what David was saying. The traction can make this problem more difficult. Now, if you do a classical ESD and you stay nice and close to the submucosa here, you're obviously running very close to the muscle there, and I think this is what happened in the second case. And what Nasa and I explained or discussed offline with you guys is when we're doing this type of lesion in my unit, I ask her to look at the mucosal fold here, and then I give her a safety margin, and then I make her to do the cut here. And the risk of having mucosal entrapment is less. The other thing is, as you extend the cut and it retracts, if you're very close to the margin here, you quickly become adjacent to the muscle. And this becomes a technically much more difficult ESD than if you're cutting here, and you're largely cutting through submucosa, and all you really have to think about are the vessels, not the muscles. Now, the caveat to that is if you think there's malignant change in the head of the polyp, you obviously got to get as close to the muscle there as possible. But in both of these cases, I think that risk was very low. And in both cases, well, the second case in particular, you could have made it a little bit easier by taking the line a little bit further away from the mucosa. So you have a clear margin here between the neoplastic tissue, but actually cutting through here is basically also just submucosal tissue that's expanded, rather than having a closer line where you get muscle exposure, which I think was one of the issues in this particular case.